Right. Sorry, that was my loud voice. We're a couple of minutes late, and I'm sure that you've got trains, cars, and who knows what transport to get you home. So just if we could just get our seats to the final bit. I'm conscious I'm the person between you and the car park and getting home, so we'll crack on. So I'm Simon Watson. I am the Medical Director and also the Director of Safety at Healthcare Improvement Scotland, and it's been a real pleasure to be here today. And I'm going to do things slightly the other way around. I'm actually going to start with a thank you before we do anything else. So I'll try and remember to finish with a thank you as well. Forgive me for being a little bit his-centric. We're going to start by thanking very much Joe, Belinda, Diana, and all the teams who've pulled this together. This is an SPSP event, and it is a team effort. I know, Joe, you've got a special place here as the head of the SPSP programme, but I just want to thank all of you for what I consider to be a very professionally run event and one that's gone very smoothly despite late challenges and everything else. And I know how much work's gone into it. So before we go any further, can we just do a little round of applause and a thank you to the people who have organised it. Thank you. Right, thank you very much. I'm also going to say thank you all for attending. I was having a conversation with somebody the other day who said, how many people do you think might be going to this event? And I said, oh, it could be 100 or a couple of hundred. So I think it's considerably more than that, isn't it? Here in the room and those online. So thank you all very much for coming. Those of you who worked with me before have often heard me say things like, your average busy person, as you all are, has got in any 1 hour about 100 seconds where they're not running to stand still, just doing the job, and maybe about 100 seconds to think about how do you improve things and to do improvements. And I know for many of you, you might consider improvement as your job, but you've still got a full load to do. So taking time out from what you normally do is really precious time for us. So I reckon there's about 100 seconds an hour, and I'm such a nerd, I've done the maths. We've had 21,000 seconds of your time since you came here. Somebody's going to do the calculation and tell me I got it wrong, but it's a big number. I think it's about 21,000 seconds. So in all seriousness, that is quite a commitment to safety, and it's quite a commitment to a Healthcare Improvement Scotland event. So we don't take that for granted. So I think from the HIS people, thank you very much for coming. Really appreciate it. Right. So what I'm going to do for the rest of the time is just quickly have a bit of a reflection on the meeting, not for too long, and then please indulge me for a minute because I'm going to talk just a bit, it's only for a few slides, about how we in Healthcare Improvement Scotland want to support improvement across the system. And it's not going to be millions of slides and death by PowerPoint, but we spent a lot of time talking about how others need to improve, but that improvement applies to us as well. We need to constantly look at what we're doing and make sure that's better. So we have, I'm hoping you're all seeing this, a word cloud, which I haven't looked at before, but this is the word cloud on the reflections from the morning breakouts. And I'll just let you absorb all of that. No meeting on improvement or safety would ever be complete if the words driver and diagram didn't appear in big letters, so that's good. The networking is one of those intangible things that is hard to measure, but when anyone does measure how effectively do things work, the degree of networking is really, really important. So that's good to see. And it's nice to see the words great session there. And I'm sure that wasn't just all of us writing that down to get the words bigger. So thank you very much. But just as we absorb that, it's good to see that oh, there we go. Outcomes has just grown a bit bigger. It's good to see within that the things we expect to see in terms of the work that we do and how we do it is really important. And it's good to see things like families and carers not being forgotten. Don't be scared of failure. Some of the best advice I ever had, along with don't fail, but don't be scared of it. I'm not going to spend a lot of time talking about this because I know we've got time to go, but I hope you've all got something out of the multitude of breakout sessions that we've had. One of the challenges of a meeting like this is picking what you want to go to. I decided I didn't want to disrupt the session and say too much, having piped up a few times in the morning, but I must say it was really interesting to be part of the session on delirium and just observe the range of intelligence that was shared, the thoughtfulness of which it was shared in, and I'm pleased that the recognition of this very serious problem is something that we're still paying attention to, so thank you. But hopefully you got something out of all these sessions. Please do give us feedback because it's the only real way that we've got evidence for how we need to make things even better in the future. So thank you for that. So just moving on to the kind of the last bit of what I was going to say, which is a bit about healthcare improvement Scotland. And this is very much focused on what can our organisation do with others to help support the whole system around improvement, and not standing still and constantly looking at what is it we're doing. And just to set the scene, and it's hard to do this in a completely optimistic way, so forgive me for starting in this place. We all know in the room that health and care systems are in a really tough place at the minute. And if we want to see an objective report on that that covers the whole system, I'd recommend you have a look at what the Auditor General for Scotland puts out. It's a bit of a crude approximation, but they effectively mark the homework of the public sector. And they've taken what I think most of us feel is a kind of general and often quite overwhelming sense of where things are at, and focused it in, hopefully, on areas that government, boards, organisations like ours and others can do something about. And I'm just going to pick out a couple of things. And forgive me if I read this, I know it's always a bit irritating, it's worth reflecting on the words. So the COVID-19 pandemic continues to affect the delivery of NHS service. I think we know that. And in particular, the huge backlog of people waiting for care has built up since the pandemic begun. And activity levels are not fully back to pre-pandemic levels, and we know that. And Scotland's healthcare system, and I think you could extend that to health and care system, remains under severe pressure operationally and financially. And Scotland's not alone in facing these pressures. These are global pressures that other countries face. And many of the factors contributing to the very difficult situation in Scotland are not specific and not within the control of the government or, by extension, organisations like ours. And I think this is a really important point. It's crucial that Scottish Government and NHS boards and organisations like his are realistic in their ambitions and clear about what has been and can be achieved. So there's quite a lot in there. But I think one of the messages that I picked out of that is, and I've heard the phrase used several times today, is the focus on what's within the circle of things that worry us, and there's a lot there around the world and within Scotland and in our own budgets, in our families and everything else, and what's within our circle of real influence or even control, the things we can control. And it's very hard sometimes not to feel overwhelmed by everything, and I feel like that myself. But one of the things about having structured and focused and methodological approaches to improving things is it does give you the tools to get into that area where we have some control. And ambition is something I'm going to come back to in a minute, because there's that balance between being ambitious and motivating people and also being realistic is a really hard place to get to sometimes. So having started on the negative, let's talk about some of the assets. I believe, and I think the evidence says, that we have very committed colleagues. You've all made a real commitment coming here today. You've deferred work that's going to still be waiting for you when you come back. We have very committed colleagues, and interestingly, some of the conversations I've had this morning reminded me that those committed colleagues don't always want to focus on the negative and how bad things are. There's an element of, we know how bad it is, we just want to get on and make things better. Clinical governance, I'll come back to this, is mainstreamed. It's not perfect. We have clinical governance in our organisation, and I don't think I'm saying anything out of turn. It's not perfect, but it's something we're working on. But it is mainstreamed in a way that somebody with a career as long as mine now, approaching 30 years, remembers it definitely wasn't going back 25 plus years. We have capability in safety and quality management, and I think that was very visible during the pandemic, when suddenly an unknown, never experienced before global pandemic infection spread across the world, and people were able to draw upon that capacity and capability to tackle new challenges like shortages of oxygen and delivery of vaccines and things like that, with the skills that are acquired through programs like SPSP and others. We have distributed accountabilities, which is a fancy way of saying it's not just the job of the chief executive or the board, and it's not just the job of the frontline clinicians. I think people understand that everybody has their role to play, although sometimes clarifying what that is can be difficult, but I think we understand that. We have national and local initiatives, and this is an important one for us, because it's no help if his is in the space of duplicating or getting in the way of things that are happening locally. We're constantly thinking there's a jigsaw out there, and how can we add pieces to the picture, not try to duplicate them? And that's something we're constantly focused on. Really importantly, and I think we all need to do more around this, but it's great that it's happening, we have patient and public involvement, we have community involvement. I'm proud that his has got a whole directorate that's now been slightly refashioned to very helpfully bring in a whole load of people with skills around strategic planning and redesigning, so that actually the voices of what the public are saying are speaking directly to the voice of the people who really understand how to change things at a system level. But that's something we've got. And we do have learning systems, although again, we're here to improve. They could be better. So we've got a lot of things going for us. But this is something I'd mentioned, I mentioned it in response to one of the questions earlier in the morning. We do also have knowledge and understanding of how to assess the risk of things going wrong beyond measuring things at a very granular level, like numbers of falls and numbers of infections. And just to be clear here, I don't want this to come out the wrong way, I'm not suggesting that we stop measuring falls and infections and so on. We absolutely need that specificity. But I think we also have got more tools that we might realise for looking at whole systems and services in quite an objective way and saying that's a bit hotter than it should be. And the risk of something going wrong there is probably higher than it is over here before something happens. And one thing you'll get sent out after the meeting is the framework, which I won't go over again because I referred to it in an answer earlier in the day, of what we as an organisation have found to be the key areas of risk, but also some quite granular things that we would suggest that boards really need to start not measuring, but bringing together as a single sort of data set and looking at to try and get the temperature of different services and spot where the vulnerabilities are. So you get an email out with this in, a bit of explanation, but if there was a feeling that this might be something you want more discussion on, we can probably lay on a webinar or something like that to explain it, because we think it's quite an important piece of work. But just to kind of wrap this up a little bit, I alluded at the start that we in Healthcare Improvement Scotland, our ambition is nothing less than to play an absolutely indispensable role in the improvement of safety and qualities in healthcare. And what that means is we've really got to look hard at what does the system need? What's the system already doing? What does the risks and the intelligence tell us are the areas that need particular attention? And how can we work collaboratively with others to really help accelerate that? Whatever metaphor you want to use, to catalyze things, make them happen better, break the ice, raise people's boats, all of the above. What can we do there? And I think a really important thing for us as a discipline is that we do it, we get things rolling, and then we try and move on to the next thing, okay? So none of this is new, but I think as an organisation, we want to really look at ourselves and say, are we doing all of that? And one of the things that I'll just share with you as a thought is sometimes to look forward, it's quite important to look backwards, because we're in a world where we've got a much more sophisticated understanding of how you manage these things. How do you do the nuts and bolts of improvement programs and improvement activities? We've got a much clearer idea of that now than we had when we started. But I found it really helpful recently to actually go back to what was almost year zero for all of this, which was 1998, early on in my medical career, when in Scotland for the first time, the government explicitly said quality and safety are now an explicit accountability for NHS trusts as they were then, boards now. And here's how it's going to work. And they wrote that in that green coloured letter. It always seems to appear in green on the internet. I don't know if it was green, from 1998, that I honestly think is a really good read to go and have a look at. And if you don't know how to find it, we can send you out the link, because it doesn't talk about the tools and the mechanics and all the sophisticated understanding we have now. And it anticipates in the future we might have a workforce who are trained in all this stuff. But what it does do is express in very, very clear terms, this is what the system needs. In language that I would suggest, and I say this with respect to the brilliant people who wrote it, in language that is usefully basic. It's very, very clear. It talks about clinical governance, not with an 8-line definition, but basically saying that it's an accountability that NHS providers are accountable for the clinical performance they deliver. And it talks about things in very simple terms in terms of those are the building blocks. And the reason I'm stressing this is I think right now, as a consequence of all those pressures out in the system, I think NHS boards want to do all of this stuff, but like everything else, will be struggling to do it as much as they will be struggling to get their waiting list down and treat patients and all the things that you're experiencing. And I just want to be really clear, they're not struggling with it because they don't understand it or they don't want to do it. It's the same capacity issues. But the problem is, if these things aren't done right, if we're not learning from adverse events in the way that we should, if we're not monitoring early signals of failure in the system as well as we should, if we're not able to catch up with things, then the risks become greater. And I feel a great sense of responsibility as HIS's safety director and MD, that HIS has got to do everything we can to make that as easy and doable as possible for the system. But in all the complexity of everything else, I do think there's some virtue in going right back to year zero for all of this, which was probably November. It's almost exactly 25 years, isn't it? November, is that, have I done my maths right? Yeah, it is 25 years, almost a quarter of a century since that letter was released. I actually think it's a useful exercise to go right back to year zero and say, what was envisaged? What are we doing? Are we achieving that? And where do we need to have different emphasis? So we are going to do what we're trying to describe as a sort of a stock take, to look at all of our programs and what we're doing, to think about what resources we have, and to try and decide how can we best achieve that mission. If necessary, we'll do it in a room just with ourselves, but you know what's coming. That's not the way we like to work. We do want to engage with people out there who are already working with us. We do want to hear, how can we best do this? How can you best do this? And we want to do it in that way that respects the fact that you haven't got too many more blocks of hundreds of seconds. So we'll try and do it in a way that's efficient, but we also want to do it fairly quickly. So it's going to be a proportionate exercise over the coming months, but that's what we want to do. I'll put the quality strategy up there as well. I haven't emphasized it, but I think there's virtue in going back to a lot of these things because they just bring clarity to issues that right now might seem quite complex. Just to throw this out there before we wrap up, I think some of the characteristics of a really impactful national program are that it's of a really good national program are that it's relevant, first of all, really does address the issues that are keeping you and your patients and your organizations awake at night. Clearly it has impact. It's achievable. Many of you who know me will also know that because I haven't got enough to do, I'm also a Cub Scout leader in my spare time. And the Cub Scouts have a brilliant quality standard for activities for young people to help them develop and stretch them, that sets a boundary between something being too easy and too hard. And it says that all the activities we do should be beyond comfort for 8 to 10-year-olds, but before terror. And I've been surprised in my career in leadership just how often the principles of Cub Scouting have relevance to the day job, because actually I think when we say something's got to be achievable, it can't just be what we're going to do anyway. But it can't be something that actually is so impossible and scares everybody to death and they have no confidence they're going to be able to do it. So I think that beyond comfort and before terror is probably not a bad definition of what we mean by achievable. And it'll also probably work for your finance directors and chief executives and the people who have to decide where resource goes. Because frankly, if they hear it's comfortable, why would they put the money there? Okay. It's got to be complementary. In other words, it's got to look at what you're doing locally and what else is happening and what other organizations are doing. And it's got to say, how can we do that? And as an extension of that, a core principle is it's got to be collaborative. And I honestly think when we look back at the best of SPSP and the other programs we've worked, that's what we see all the way through. And I think it's not about dwelling the past, but some of the things that we now look back and say that was achievable were definitely thought to be impossible when we started out. So final slide from me is Healthcare Improvement Scotland has got a new strategy for the next 5 years, and that's a big part of the reason why we're doing this. We've signed off the strategy. It is a 5-year strategy. We're now taking it from strategy, which is that's the end point that we're working towards, to how we're going to do this operationally and working back from that. That's part of the reason, most of the reason why we're doing this, as it were, stock take. Say, if you read our strategy, you will find safety and allusions to safety from start to finish and in every place. And the good thing is, it's not only about the things that are rightly very high profile and you would associate with safety, like SPSP and our other overtly safety focused programs, but actually it's about what can we do around guidelines, community engagement, quality assurance, learning from adverse events and everything. How do we bring all of that up? So the 4 priorities around really having a better understanding of safety and how can we identify high impact opportunities, how can we use intelligence and evidence to best support the system, how can we make sure that the views and rights of patients, the public and communities are heard, and how can we really deliver practical support to help improve things. That's the strategic aim, and we want to do that in a way that's absolutely indispensable. So that's the journey we're on. You will be getting directly or indirectly or through whatever messages about the stock take and what we're doing, and an invitation to help us out with that. We do need to scope out what it is because our busy teams have been somewhat occupied with this and everything else that we're trying to do. It will be fleet, it won't take forever, and it's not, just to reassure some of you, it's not about throwing out everything we're already doing, it's about really making sure that we're doing what we're asking everyone else to do, which is to have impact. But hopefully that's some useful context of what we're thinking. And I'm going to finish where I started by saying thank you all again very much for coming, for the 21,000 seconds you've given us, and for all of your thoughts and ideas. It's so heartening to see this much enthusiasm and support for the thing that we make our full-time job. We can't do anything without feedback. We're in the world of QR codes and other fancy things. They're on the tables and everything else. And please give us our evaluation. And let's finish with a final thank you, not to the people who already thanked, but to the wonderful staff at this amazing facility, which I'm proud to say is owned by the NHS, who always look after us really well. Let's finish with a round of applause for the staff at the Beardmore. Thank you.